Good evening. This is United Medical ACO, our Wednesday wellness webinar. And my name is Kemal Erkan. I'm the chairman of United Medical ACO. This is our monthly event, second Wednesday of each month. And also we have a fourth Wednesday of each month, our support group for our patients with diabetes. And today we have a specialty guest from one of our practices from the ACO. Before I start our presentation, as many of you know, there is a huge natural disaster happening at the moment in Turkey. That's the country that I'm from, and the devastation level is not easily probably measurable. So this is one of the biggest we have ever seen. The people do need help. We, as United Medical family, we try to send our help, and I know that many others are helping. And I do want to share our link, which people who are watching this can find this on my Twitter channel. This is an official account for the Turkish government, and this is a safe link. And hopefully, anyone out there who are watching this can contribute, and we would appreciate that if that can happen. All right. Well, now. When we have these real life issues, sometimes going into our routine business is challenging, just because we still have to do this while we have all these troubles happening, and sometimes just to make ourselves feel better. I feel like sharing is the best way to channel that energy into something positive. And hopefully everyone understands where I'm coming from. So our program, as many of you know by now, Dr. Ripu Handal, our program director, who's our endocrinologist from First Aid Endo, Caroline as our head dietitian, and also Donna Gunkel, our director of clinical integration team and operations. So they are with me. And we are going to discuss the kidney disease and diabetes. And Dr. Dhruv Patel from Kidney Care Associate is going to give us the presentation. Dr. Patel, how are you doing?
I'm good, Kemal. Thank you for having me. And before I begin, my heartfelt condolences to the people affected in Turkey. And obviously, we are here to help any way we can.
Thank you. All right, so as we said, the discussion is kidney disease and diabetes. So Dr. Patel, you are on.
Good evening, everyone. I'm Dr. Patel. I'm one of the nephrologists, the kidney doctor, serving Delaware for almost more than a decade at Kidney Care Associates. We are two physician practice, myself and Dr. Ramal Patel, and we are nurse practitioner. We have two locations, one on Delaware Avenue in Wilmington City, one near Christiana Mall in Christiana Medical Center in Newark. And we do provide services at all the hospitals, including St. Francis, Christiana Care, and Bay Health in Dover. So Kemal, thank you for having me here today. And today we're going to talk about diabetes. So before I begin, I just want to point out that what we will focus today mainly on. Number one is why it's important to know about diabetes and kidney disease. Number two is what are the types of diabetes and how it can affect the kidney disease. Number three is that how the doctors or the physicians can diagnose diabetic kidney disease. Lately, we'll focus on once diagnosis is being made that patient has diabetic kidney disease, what can we do as a team to slow down the progression of the kidney disease and prepare for the best outcome for the patients and the family. So let's begin with that, why it's important to talk about and understand about diabetic kidney disease. So I just want to focus few numbers, which is at a moment, if you look, it's quite scary number. In the United States, 14% of the adults had low GFR along with the protein in the urine or both. And these are based on 2017, 2020 data. So basically, in nutshell, when GFR means the percentage of the kidney function. So if you look out of 100 people, 14 people would have some degree of low filtration rate, meaning low kidney function. And KDIGO, that's the kidney disease improving global outcomes. They, out of that 14%, 10.5% had a moderate risk of kidney disease. That means they have highly likelihood of progressing to end-stage renal disease, where patient needs dialysis and or kidney transplant. Almost 2% as higher risk. Now, unfortunately, the prevalence of diabetes has been increasing with or without kidney disease since 2005. And now it's almost like 9.5% in those even without CKD patient, without chronic kidney disease and diabetes. And now if we're gonna look at this number, 35.6%, with diabetes and the kidney disease, those patients are at high risk. So if you look, the patient with diabetes, they have almost like 3 times more risk for the kidney disease than those without diabetes. And unfortunately, end-stage renal disease, where patient needs dialysis, number has been steadily going up since 2000 to 2019, 95,000 to almost like 150,000. Which is almost like 40% increase in last almost 20 years. Can we go to next slide, Kemal? And as mentioned, diabetes is one of the leading cause of the chronic kidney disease and end-stage renal disease, whether it's the United States or worldwide. And prevalence of diabetes in the US has been increasing steadily. Now it's almost 6 to 10%. And despite of unfortunately, the problem is that CKD awareness is extremely poor in general population. And I think the main reason behind that is, in general, chronic kidney disease at early stages will not cause any symptoms. You don't feel sick having kidney disease until your kidney disease at a later stage, where you are almost needing dialysis. That's when the symptoms start, whether you have like swelling, you have trouble breathing. So this is kind of silent killer. Only way to know or diagnose a kidney disease at early stage is blood work and the urine test. So only 10% of the people knows that they have kidney disease. Yep, good, next. So again, this 1 in 7 people, unfortunately, have chronic kidney disease in the United States. And out of 1 in 3 adults with diabetes and high blood pressure have chronic kidney disease. So almost like 33% patients with diabetes or high blood pressure would end up with some degree of the chronic kidney disease. And that's why it's important to focus on diabetic kidney disease. Next slide, come on. So there are 2 types of diabetes. As we know, there are type 1 diabetes and type 2 diabetes. Type 1 diabetes is the early onset. Patients basically has insulin deficiency. The body, in a layman's word, that body does not make enough insulin. So in other words, kind of insulin dependent diabetes. The younger age children also have diabetes type 1. And those are patients at a high risk for developing chronic kidney disease, just because the diabetes started at an early age. So they are highly likelihood of having adverse kidney outcome down the road, just because exposure of diabetes is duration is much more higher compared to type 2 diabetes. Second class of diabetes is type 2 diabetes, or what we call is basically insulin resistance. The body has enough insulin, but the cells does not respond to that insulin, and that's why the glucose level goes up in the blood. And type 2 diabetes, majority of the time is in elderly people, and high-risk patients are more obese, and that obesity itself is a risk factor, and it causes more insulin resistance, end up with type 2 diabetes, what we call like a metabolic syndrome, where they have obesity, diabetes, high blood pressure, sleep apnea, and all other comorbidities. Type 2 diabetes is also high risk, but less compared to type 1 in terms of the chronic kidney disease. Next slide, come on. So once you have diabetes, it's important that as a patient, we are aware, or we need to know what my doctor is looking for when I go for the blood work or the urine test, how my provider can diagnose that how my diabetes is causing the kidney problem or it's not causing the kidney problem. And fortunately, it's a very simple test. It's not expensive test. Basically, you can have a urinalysis, which sometimes can be done at the primary care office or LabCorp, Quest, or any other diagnostic facilities. Urine test is a simple test. We used to do a 24-hour urine, and we don't recommend doing 24-hour urine anymore. Just the random urine sample is enough. Basically, what they do is they check urine protein to creatinine ratio, and it's a random test, and that tells the doctor how much protein you are spilling in the urine. If you have diabetes and the protein in the urine, that means that kidneys are, that's the first indication, having protein or microprotein, what we call microalbumin in the urine, appears in the urine. That's the first sign of having chronic kidney disease. I did mention the 24-hour urine because there are some old thoughts. Physicians are still recommending 24-hour urine, but in the nephrology world, we don't recommend 24-hour urine as a diagnostic test. If we have some questions about the random urine test, then we go for the 24-hour urine, or if patient are more muscular and has some high level of baseline creatinine, then we do recommend 24-hour urine, but otherwise random urine is enough. Blood test. In blood work, when you get your complete metabolic panel or basic metabolic panel, always look for BUN and creatinine. That tells that how good or how bad is the kidneys. So the creatinine is basically the toxins or the waste product in the blood that we check. Normal creatinine is 0.8 to 1. If that number goes up in the blood, that means that kidneys are not able to release the toxins or the waste product from the blood. And that's why that number goes up, whether it's BUN or creatinine. 0.8 to 1 is the normal range. If that number is going up, that means you have kidney disease. Nowadays, labs also reports the GFR. That's another way of looking into kidney numbers, what we call glomerular filtration rate. In a simple language, I would say it's the percentage of the kidney function. How much is your kidneys are functioning, or how much is the kidney filtering the toxins, and that is the GFR. Next slide. So I do come across this question that, Doc, why do I spill the protein in the urine when I have diabetes? So easier way to explain is that kidney is like a lot of filters in the kidneys. Basically, we have refrigerator and the filters. Same thing the kidney does. The blood goes to the kidney. It filters the, ideally, if your kidneys are normal, healthy, your filters are healthy, then your kidney filters are supposed to reabsorb the protein rather than leaking in the urine. But when you have diabetes or blood pressure or obesity, the main risk factor is diabetes. Your kidney filters get more scar, what we call like sclerosis. Basically, if you have some wound, it gets scar, like you have some white fibrous tissue happens when you have injury. Same thing over the period of months and years of diabetes, having high blood glucose, kidney filters get scar, and rather than holding on to the protein, it gets leaked in the urine, and that is the first indication of the diabetes affecting the kidneys. So diagnosis of the diabetic kidney disease is when you have GFR, as I just mentioned, the percentage of the kidney function drops below 60. That's when actually the lab picks up, because stage 3 chronic kidney disease is when the GFR, the percentage of the kidney function, drops below 60. Unfortunately, above 60, the lab normally reports is more than 60. So 60 to 90 is like stage 2 kidney disease, and 90, more than 90 when you have just the protein in the urine with normal kidney function gives you stage 1 chronic kidney disease. So there are total 5 stages of the chronic kidney disease. Stage 1 is if your kidney function is normal, but if you have protein in the urine, or if you have structural problem to the kidney, whether you have one kidney or one kidney is part of the one kidney is out because of the cancer and so on and so forth, or you're born with the smaller kidneys, that's stage 1. Stage 2 is when kidney functions between 60 to 90% with or without protein in the urine. And then more serious problem starts in stage 3 kidney disease when the GFR, or the percentage of the kidney function, drops below 60. Now, we also divide stage 3 into 2 categories. Stage 3A is stage 3A between 45 to 60, and stage 3B is between 45 to 30%. And stage 4 kidney disease when your percentage of the kidney function drops below 30%, and that is where more severe kidney disease we have to think about, and then we start preparing about what can we do to slow it down. And if kidney disease does end up progressing, which can happen if the diabetes remains poorly controlled or blood pressure remains poorly controlled, then we refer for dialysis, renal replacement therapy, and all that other options that we talk about that. And stage 5 is basically almost dialysis.
I was just opening the image, so then I didn't want to interrupt the presentation, but this is easier to go through.
Yeah. Yep. So I was in stage 4, which is between 15 to 30%, and that's where your kidney function is below 15 to 30%, and it's called severe kidney damage. And stage 5 is when the kidney function drops below 15%. And that's where we start talking about dialysis. What's the next step? Whether it's transplant, what kind of dialysis patient and the family would prefer, whether they want to go to the center or they want to go and do the dialysis at home at night, which is more popular, more convenient, and that's the better option for the dialysis, or what we call renal replacement therapy when the kidney fails.
So, Dr. Patel, I have a question. In our case conferences for the United Medical ACO, in some cases we see some patients from the primary care, and we all, as you know, we do look at the lab results, and I see the patient with the GFR lower than 60. And then it's maybe 2 consecutive ones, like the 3 months apart. And in some cases, we still don't see the diagnosis for kidney failure. Is that normal?
So that's not normal because obviously stage 3A kidney disease, if you see if not more than 90 is higher, you already has lost 30% kidney function away from the normal. So that's not normal, and obviously all physicians should be documenting that they have stage 3. And why it's important more than ever before, Kemal, is that now in last 1.5 years, there is a lot of excitement happening with the new modalities, new medications, and I'm going to talk about that in later. So if we target the patients with the new approach, new therapeutic medications, it would be really helpful, because data has shown number of times in last 1 year that we can actually, initially we thought that kidney disease is going to progress and we can slow down the kidney disease progression. But in last 1 year, the pendulum has been shifting, and now we have some data that new medication would help improving the kidney function too.
So, Donna, we are doing the right thing, because we did actually send the patient to you. And I think maybe we should also present this in the ACO meeting one of these days, because something that you said earlier that caught my attention, which I use that a lot. And in medicine, there are some old school learning where if the things are not being renewed or refreshed, then we may still be approaching the patient in the old way, where there are a lot of new things available. And then that's why when we are going through the screening, we always look at the labs and make sure that sometimes, even if we are, if you have to insist in some cases, because it's safer. If someone is, if you have 2 GFR lower than 60, I mean, if you see the patient and if you decide, okay, there is no follow-up needed, it's one thing, but what if there is a follow-up? So we don't want that to be late, and that's why this is extremely important. But thank you for answering that. So I'll go back to the presentation.
Yep. So protein in the urine, one was GFR is the percentage. Second is the protein in the urine. And as I mentioned, if the protein in the urine is more than 30 milligram, that microalbumin, that's a little, like a tiny protein, then the macroalbumin, which is albumin to creatinine ratio. The microalbumin is the first sign of having chronic kidney disease, because before the big molecules leaks from the filters, the microalbumin, which is the little micro, as the name says, it will leak first. So if your patient has microalbuminuria, even the GFR or the creatinine is okay, they do have chronic kidney disease, and they need to be seen at, with the specialist to see what can we do to A, diagnose, and B, slow down, and C, maybe reversing the kidney damage. Typically, annual screening of the diabetic kidney disease. So when you have type 1 diabetes, ideally they do recommend having the kidney disease screening with the UN creatinine and the urine test 5 years after type 1 diabetes. Again, because type 1 diabetic patients typically has, they're younger compared to type 2 diabetes. And if you have type 2 diabetes, even at the time of diagnosis, they should get screening for kidney disease, including the BMP, meaning UN creatinine, and the urine test. So there are 3 ways to look at the protein in the urine. Less than 30 is normal. Micro, meaning that small molecule of the protein is being spilled between 30 to 300. Those are the low risk factors, but again, that's the early sign of the kidney disease. And sometimes when we see the patients, they already have more than 300 protein, and that means that they already have established diabetic kidney disease. And then obviously they need more intensification of the diabetes control, blood pressure control, and so on and so forth. So I want to point out, even though this is the old slide, it's multiple times being presented in many presentations. Why? Because blood pressure control, along with the diabetes control, is also the key factor in reducing the kidney disease or slow down the kidney disease. So patients in this slide, basically what it says is that patients who have mean arterial pressure more than 100, 110, they are more likely to have progressive chronic kidney disease at a faster rate compared to patients who have normal blood pressure or relatively low blood pressure. And those patients would have more time before they progress to the end-stage renal disease. Next slide. So now we have diagnosis already of diabetic kidney disease. Now, what can we do? What are the risk factors and how can we modify? So there are 2 kind of risk factors, modifiable and non-modifiable. Age, ethnicity, and male sex. There, unfortunately, nothing can be done for that. African Americans, Hispanic population has unfortunately higher risk for progressive chronic kidney disease compared to Caucasians. And more the older you are, high likelihood of progressive chronic kidney disease, just because your filters, because of the age and diabetes, is already scarred, and it's hard for older kidneys to kind of bounce back compared to younger kidneys. Now, what we need to focus is on modifiable risk factors. So I normally tell patients 5 things is important. Number 1 is diabetes. That's number 1 goal, to bring down the A1C, because better the diabetes control, better the kidney disease outcome. Second is blood pressure control. Typically, we do recommend if you have diabetic kidney disease, blood pressure should be less than 130/80. Cholesterol control is important. If you are overweight, like obese, that's clearly a risk factor for the diabetic kidney disease. Weight loss is a big thing about avoiding the progression of the chronic kidney disease. If you are a smoker, again, the high risk, because the smoking causes tiny blood vessels in the kidney to get clogged up. Like you're high risk for the stroke, you're high risk for the cardiovascular problem. Same thing happens with the kidney if you're smoking. So quitting smoking, never too late. Next. So blood pressure control. Now, when you have diabetes, there are certain medication helps two-way. One is controlling the blood pressure, and those are the medication also helps with reducing the stress on the kidneys by controlling the protein in the urine. So what we call in the medical world, it's called ACE inhibitors or angiotensin receptor blockers. And fortunately, this medication are also helpful for the patient with heart disease or heart failure. So it kind of serves three purposes: protein in the urine control, healthy heart, and blood pressure. Like lisinopril, quinapril, losartan, valsartan, those are the medications which would recommend for the blood pressure control if you have diabetic kidney disease. And there are a few data about spironolactone that also helps with lowering the protein in the urine. Next slide. So glycemic control, diabetes control is most important thing when you have diabetic kidney disease. If you don't have much more other comorbidities, meaning that you're not elderly, no dementia, or no end-stage diagnosis, then we do recommend A1C, tighter A1C, less than 6.5%, provided there are no low blood sugar episodes like hypoglycemia happens. It's safer to do than A1C goal should be less than 6.5 to help slowing down the kidney disease. But individual goal is important. That's why it's a collaboration from endocrine doctor, primary care doctor, and the nephrologist to set the individual goals that what should be the target. Because if patient has limited life expectancy and a lot of other complications, then A1C of less than 8 is okay too. And if patients are more older, when I said more than 65, majority of the time, if they are more than 75, the glycemic control can be a little bit relaxed, just because they are more patients who can fall more with the low blood glucose, and as long as they don't have other comorbidities like chronic kidney disease, then liberalization goal of 8 to 8.5 should be okay. But again, it's all depending on your other comorbidities, your age, overall life expectancy, and that's why it's important to have multidisciplinary approach in managing diabetic kidney disease. Next. So this is the excitement that I was talking about in last, I would say 6 months or a year. And I would say every 2-3 months when I open the New England Journal of Medicine or JAMA, there are articles coming. The good thing about these are the agents that helps slowing down the kidney disease. In fact, we always say that, we always thought that kidney disease is a progressive chronic kidney disease, and what we need to do is we can slow down the kidney disease. But this couple of the agents like dapagliflozin, I think they're marketed as a Farxiga, and there are a lot of commercials coming for Farxiga, Jardiance, and K for kidney, that's at Corindia. So these are the 3 medications now came in the market, and that has changed the way how we thought diabetic kidney disease should be managed. And there are a few data that your GFR improves with the Jardiance and or Farxiga. So dapagliflozin is Farxiga, empagliflozin is Jardiance, and finerenone, that's Corindia. So these are the 3 new medications now we have in our arsenal to slow down the kidney disease. And there are many data that not only it helps the diabetes, not only it helps the diabetic kidney disease, and there are many data coming that it's also protective for the heart failure patient, whether they have any congestive or systolic heart failure or diastolic heart failure. So this is becoming kind of a new era of diabetic kidney disease management because of these 3 agents. Next slide. So this was just before a couple of weeks in New England trial came that empagliflozin, it reduces the risk of kidney disease and all cardiovascular death in people with chronic kidney disease. So it was super exciting article, just came out before a couple of weeks only. And even in this particular trial, they did include the patient with diabetes and even without diabetes. And the results were the same, that it does decrease the progression and it protects the cardiovascular, it prevents the cardiovascular death. So that's a super exciting news coming from Jardiance. Next slide. So again, this is a busy slide, but what I want to show is that this was, again, before, not far in New England, this medication called Kerendia. I think they market as a K for kidney. It's called Finrenal. And the data is the same, that patient with Finrenal use with the diabetes, whether they have protein in the urine or they don't have protein in the urine, their kidney disease progression was much slower. And there were some cardiovascular benefits too. And basically what it does, it decreases the inflammation in the kidney filters, and it improves the kidney disease outcome in the patient with diabetes. Next slide. Now I just want to spend 2 minutes on ACO and diabetic kidney disease. So diabetes is kind of a life-changing event in any patients or the family, because there are many doctors, they need to talk to each other, because a doctor says, and I understand patient frustration sometimes, because a doctor is saying that metformin needs to be stopped or Jardiance needs to be stopped because of the kidney disease. And that's where I think there is a value in ACO, because it's a multidisciplinary approach. We have endocrine doctor, we have primary care dietitians. More advantage is that we all share the EMR, and it's just a close communication. There is no gaps in the coordination of the care. The care management team is there to help. Social worker is there to help with some social issues, insurance prior authorization, and so on and so forth. So definitely it is important to have a multidisciplinary approach and coordination of the care. Now, patient is in the hospital with diabetic ketoacidosis, their sugar is like 700. They're discharged on insulin or whatever medication, typically insulin. Now, they need to have a follow-up with endocrine doctor, primary doctor right away, because it's ongoing management. The hospital, what they do is they'll control the sugar time being, and patient will be discharged with instruction to follow up with primary care. And that's where this care coordination and multidisciplinary approach is important to work as a team and have the best patient outcome.
Well, no, Dr. Patel, that's really important, as you mentioned. So one of the things that we are trying to do on the ACO side is to identify the patients before they go to the hospital. So as you know, we have 2 case conferences in the morning with our nurses. So, and there are patients with chronic issues. They don't have only one of them. They usually have 3, 4 of them all together. So sometimes it's overwhelming to deal with, take care of those issues at one visit. So our care coordination team, our nurses, we actually go into each chart, check the external resources, find whatever we can find to complete the missing pieces. So then that's why I was asking you earlier about the GFR, and we do a lot of A1C management, because most of patients do have high A1C. Morbid obesity is one of the most maybe undertreated chronic illness. And as you know, we see this, what we can do to eliminate or prevent the hospitalization is kind of the key, or before the problem becomes a lot more severe. I'd rather have you see the patient than telling us, okay, there is no need for the follow-up, versus we take that chance and then it's already too late. But thank you. Now, Caroline, I think we are starting with your slides now.
Yes.
All right.
All right. So tonight we're going to talk about potassium in the renal diet. So I believe last time when we discussed kidney disease, we would focus more on sodium, but I've gotten a lot of questions about potassium lately during some patient appointments. So each patient we know with kidney disease is different. So their needs are different depending on their labs, what stage of CKD they have. Everybody has different nutrition needs. So ultimately, we want to make sure that the blood sugar is controlled and there's specific nutrients that we want to pay attention to when dealing with kidney disease. So I mentioned sodium, there's phosphorus, and here we have potassium. So when the kidneys are struggling, we'll end up not being able to remove that potassium, right? So potassium, we know, is an important mineral found in foods we eat. It does a lot of things. Here we have listed electrolytes, helps maintain bone health, muscular function. So excess potassium is removed by the kidneys normally and excreted in urine. And if the kidney function is impaired in any sort, that blood potassium level can rise and it can become pretty harmful. So it's important to note that not all patients at any point need a potassium restriction. So consult with your physician, your dietitian. So obviously your lab work will show that. So this is strictly for if you've been put on a potassium restriction, kind of what to pay attention to. So next slide. So how to limit our potassium in our diet. So we work a lot with label reading, making sure a lot of foods these days will have increased potassium, especially paying attention to those like the low sodium foods, right? They'll replace the sodium actually with potassium chloride. So those contain high levels of potassium. So I think one of the examples that I've seen lately have been like the low sodium V8 juice. Has about 140 milligrams of sodium, about 900 milligrams of potassium in 8 ounces, compared to the original V8, which has 640 milligrams of sodium and 460 milligrams of potassium in 8 ounces. So paying attention to reading your labels closely. And here's just a picture of just a can of beans where we see that we have a pretty high content, about 1/4 of the daily value of potassium here. Some goals, depending on the patient, might be around 2 grams of potassium per day, could vary. Again, you talk to your doctor, you talk to the dietitian about that, but we want to limit or replace the high potassium foods in your diet, keep reading those labels, measuring and being aware of your serving size and portion of foods. So on the next slide in a minute, we'll talk about different variations of high, medium, low potassium foods and how to incorporate them into your diet. So portion size matters. Stick to your potassium limit that you discussed with your doctor and dietitian. Draining canned vegetables and fruits and meats before eating them, that can actually reduce sodium and potassium. So I always recommend rinsing your beans, rinsing your canned vegetables. I think it reduces it. Last number I heard was about 40% on average. The 40% of the potassium and the sodium are washed away when you're rinsing your products. And then leaching vegetables, which we'll talk about at the end, but that can help decrease this potassium content as well. So we have high, medium, and low potassium foods. I could not fit all the pictures of all the foods on here. So these are just go-to foods. On our high potassium, you'll see artichokes, avocados, beets, greens, potatoes, prunes, raisins, bran, a lot of commonly used foods. Then we have moderate potassium foods, which they have just like they're on the spectrum. So they're just centered in the middle. Things like asparagus, broccoli, we've got some frozen vegetable medleys, ice cream, there are even some mangoes and fruits on there and some rice as well. And then we have low potassium foods. So this is the one when we're sitting in counseling talking about foods to include more often when we're having a potassium restriction. We want to go for things like maybe some eggplants, some pineapples, some watermelon, beets, things like that. So those types of fruits, vegetables would be more commonly used. You'll see that like peaches are a moderate food on the left, and on the right, canned peaches are lower potassium. So some foods in the canning process can have a lower potassium content through the processing system than just a fresh piece of fruit. So what about the high potassium foods and the moderate potassium foods? Can you have them ever? Because I get a lot of patients who get really, really upset on the potassium restriction. The answer is yes, they're not completely 100% off limits, but we want to look at that portion size and we want to monitor them in the frequency, right? We don't want to have high potassium food potatoes every single day, right? Because then you get labs back, potassium's elevated, and we really want to do diet adjustment by what recent labs say. So usually if your potassium is in a good range, it's clear as okay with the doctor, we'll work on incorporating those moderate to high potassium foods often, but again, not every day, and focusing more on those lower potassium foods. So earlier I had mentioned leaching potatoes. So one small potato has about 700 milligrams of potassium, and the average size is about 926. So if you think of that on a scale for like a 2000 milligram or 2 gram restriction, that's taking up a lot, especially if you're having, multiple potatoes or you're having other potassium rich foods. So it doesn't mean you have to cut out potatoes entirely because they are high in potassium. Certain high potassium foods can be soaked in water or leached to decrease the total content of potassium in a renal diet. So leaching means a way to drain or filter out. So by leaching and soaking the potatoes, it'll help decrease the sodium content or the potassium content, but it won't get rid of it completely. So you still have some small potassium amount in there. It's not recommended that you leach all vegetables or soak or boil vegetables for an extended period of time because there are certain water-soluble vitamins like vitamin C, vitamin B, that can be lost during that process in the water. So all vegetables are different. Talk to your dietitian if you want to leach certain vegetables. We can talk about the specific ones that are okay. And we want to make sure that all vegetables don't lose the same amount of potassium when leached or boiled. So it's important to talk to dietitians when you're going through this process and trying to see which vegetables to leach and which ones to just eat or rinse naturally. So we'll go through tips for leaching potatoes, just because it's a pretty simple process. So what you want to do, if you go to the next slide for me, there is a couple pictures for our instructions. So you'll want to wash and peel and cut the potatoes into pieces approximately about 1/8 of an inch thick. We want to make sure we get enough of the surface area in it. We don't want to put the whole potato in it because we want to have the most of the potato touching that water to have the potassium leach out. So we want to rinse it and soak them for about 2 hours using approximately 10 times more of the unsalted water than the vegetable. And then you're going to drain the water and rinse the potatoes under warm water and boil for 5 minutes or cook however you want to cook them, whether you want to saute them or not. But again, don't do it for an extended period of time for all different vegetables because we don't want to lose the nutrient value in the vegetable. So overall, we only want to restrict that potassium when instructed by your physician or your dietitian. We want to manage your blood sugars, of course, in this process as well, but also practicing reading your nutrition label. You can learn a lot by what's in a food by just reading what's on the back of the package. And a lot of packaged goods or canned goods can have that potassium added in during the process, or it can just naturally have potassium in it. So familiarize yourself with that low, moderate, high potassium foods and be on the lookout for what you want to limit, what you want to include more often. And of course, speak to your dietitian about ways you can include those moderate to high potassium foods during your diet. And that is it.
I always say these every time we go through one of these, so I didn't know about this leaching part of it, so I learned something new. That was helpful. Any questions?
I don't really have a question, Kemal, but I did want to circle back to something that Dr. Patel said. And I know I kind of mentioned this in several of the sessions that we have, but I think it's important from a patient education. Dr. Patel, you mentioned very early on that a lot of times patients don't realize the extent maybe of their disease process because they don't have any symptoms. And I think that's one thing that we hear from many of our specialist, our endocrinologist, our cardiologist, our nephrologist. So again, just putting that back out there, the importance, I believe, that you were pointing out is getting your lab work done. So when your PCP orders that lab work, get it done so that they can see that and diagnose things early on, keeping the other things in mind that you indicated. If you're newly diagnosed with type 2, getting to a nephrologist to be assessed, and then periodically after that. So we just like to get those things out there, because Kemal mentioned like a lot of our case conferences, and we see patients who have stage 3A, stage 3B. It doesn't appear that they've been referred to a nephrologist. They may have had diabetes for a long period of time, at least as far as what we can see. We also see patients who have very high A1C, and we hear from them, oh, I don't need to see a dietitian. I don't need to see an endocrinologist. I know what to do. I feel fine, but then we find out that their A1C is 13. So I didn't know if you wanted to add anything else in about that, or you, Kemal.
Yeah, so Donna, thank you for bringing that up. Absolutely. As I said, the problem is that, unfortunately, I didn't mean to scare anyone or patients, but it's not unusual that we end up seeing in the consultation in ER when patients' kidneys are 2% or 3%, just because now they are not able to pee, they have like swelling, they can't breathe. And by that time, when they get the labs, only thing we have to offer is dialysis. And as I said, it's a silent problem, and only way to know is awareness in the patients, physicians, all medical fraternity in general, because labs is the only way to diagnose early and act early. Otherwise, I would say prevention is the key here, because by the time you already end up with stage 4, stage 5, yes, we can still work on that, but stage 3 is the target group, because that's where the real kind of medication, we have more medication to offer at that stage, because once kind of too late, too little, we don't want to do that. And I agree that awareness and labs, blood work and the urine test, it's probably, it just takes 10 minutes to get that test. And that's why I asked that 24-hour urine is not needed. So just the random urine test and blood work would suffice, and it would be helpful.
So again, one of the things that you used earlier is modifiable. So in order for us to have the modifiable situation, we have to act early. So these are modifiable if it's at a low level, low severity, just like anything else. So we cannot undo the aging. We cannot undo the sex, race. Those are all kind of like already set for us. So, but we can work on when we are identifying, diagnosing these patients. And I think, I don't want to brag about this too much, but I think our care coordination team with the nurses, what we do now, we can actually see how, because patients sometimes don't want to participate in that, so they're not helping. And I'm not blaming any patient, don't get me wrong, but when we talk to them, so like today, someone just hung up on me during the case conference, and all I was trying to do is help the patient because the A1C was so high. So someone with the, from our case conference, we when we follow up on the blood work, we see the A1C like 13, 14. We saw as high as like 15, and they haven't seen anyone yet. Mm-hmm. Those are making these situations a lot more difficult to manage. And I think that's one of our goals for these events, to make sure that we can increase the awareness of the disease and how we can actually more effectively fight with these diseases and help our patients. And I do want to thank all of you for taking time and being with us tonight. And then again, our support group is on the 4th Wednesday of this month. And those who are interested in the support group, you can register through Zoom, which is on our United Medical website under the patient portal. And Again, thank you, everyone. We'll see you next time.
Great. Thank you. Thanks, everyone.
Bye-bye.
Good night. Thank you.